Welcome to Team Gut Girls, the podcast for anyone who's ever unbuttoned their jeans at 10 a.m., mapped out every public washroom in a 10-kilometer radius, or wondered why one bite of food can ruin an entire day. We talk about bloating, constipation, diarrhea, reflux, nausea, abdominal pain, histamine chaos, and all the quiet gut symptoms you're told to just live with. Join naturopathic doctors Dr. Whitney Baxter, Dr. Christina Carew, and Dr. Dominique Vanier. Your gut is talking, and we're here to help you translate. You're with Team Gut Girls now. Let's dig in.
And before we dive in, just a quick note. This podcast is for educational and informational purposes only. It's not meant for medical advice and doesn't replace working with your own healthcare provider. We're sharing general information, not diagnosing or treating anyone. Please always talk with your physician or licensed healthcare practitioner prior to making changes to your health, medications, or supplements.
Welcome back, listeners. I'm joined by my Team Gut Girls co-hosts, naturopathic doctors Dr. Whitney Baxter and Dr. Christina Carew, and our honorary baby member on my lap today. Today's topic is all about constipation and bloating. So in this intro, we're first going to define what constipation actually is. And so it's clinically defined as infrequent, difficult, or incomplete bowel movements. Constipation, as we know, is actually a major cause of abdominal bloating. So up to 90% of constipated patients experience bloating. In one multi-center study of about 2,200 patients with functional constipation or IBS constipation, bloating prevalence was really high. Over 90% of the participants with either functional constipation or IBS constipation reported bloating. So there is a really strong connection there. We also want to distinguish that constipated people are more likely to have both bloating and distension. So we've talked about this in previous episodes, but we'll redefine it here. It's a subjective feeling when we talk about bloating. So that means that we feel like there is, for example, a balloon in the abdomen, whereas distension is more like an increase in physical girth. So for example, patients will describe like looking in the mirror and saying that they feel like they look 6 months pregnant. And often people will have both bloating and distension present together. And so there are many reasons why somebody who is constipated is more likely to experience bloating. And one of the main ones is because they actually have retained stool. And that's going to increase a few different things. So that will lead to an increase in colonic volume, an increase in luminal distension. It'll change the stretch signaling. And all of these can contribute to feelings of fullness, pressure, and bloating in somebody. And so some of our listeners may know it's like an objective tool that we use in practice called the Bristol Stool Chart. So constipated people are typically at the type 1 or type 2 on the Bristol Stool Chart. So type 1 is described as like those, tiny rabbit pellets, and type 2 is just a little bit larger than that. And both of them are seen and if you don't know what this chart is, it's great. So look it up online. But one major myth we want to go over is that if you're having a bowel movement daily, this means you can't be constipated, and that's not true. So stay tuned because we'll talk a little bit more about how we can still be constipated when we are actually having a bowel movement daily. And constipation can be any of the varying degrees that we just described above. So with that intro, maybe we can dive into Christine and Whitney. Have you seen any difficult constipation cases recently?
Yeah, for sure. I would say it's like an everyday someone is constipated of some level. And it doesn't mean that you couldn't be constipated and have another reason for bloating. And I think that's a piece that listeners need to realize is that, so I have one patient, she's still with me, 4 years of working through constipation. But one of the things we recently figured out is that she has a lot of internal hemorrhoids. And so when her internal hemorrhoids are really flared, she has a really hard time getting the stool to pass through because the passageway is decreased in volume. And so one of the ways that we figured out that was part of it is, I think we'll probably talk about this later, is doing a change of timing test. And it was like several days before her stool passed. So we knew that she was like not only backed up, but because she was getting blood on the stool, it was like sort of this combination sort of situation. So keep in mind that constipation alone may not be your bloating problem. But part of it
Yeah, that's really helpful. It's incredibly common to see hemorrhoids in constipation. And interestingly, even the patients that have like a mixed presentation, so like they go back and forth between constipation and more the loose end diarrhea, even the diarrhea or the loose bowels is enough to aggravate the hemorrhoids. So we don't always need to be constipated to have an aggravation of our hemorrhoids. What about you, Whitney? Any tough cases lately?
Yeah, I'm like you both, where the majority of my bloated patients were talking about constipation or this hidden constipation. And a lot of it is my busy mamas. So they get up and their whole morning routine is dictated by their kiddos and getting them out the door. So they don't have that slow intro to the day. Even me, I try to wake up at 5 a.m. to have a moment to myself. But whose little door opens when they hear the coffee machine turn on? It's my 5-year-old. So we do our best, but if we don't have a ritual and a slow, calm ritual sometimes, then the nervous system just switches into go, go, go mode. And it's hard to have that like full, complete feeling of a bowel movement.
Yeah, that's definitely really helpful. We do talk a little bit more about this, which is we need our nervous system to be in more of like a calm state to really allow for that gut brain connection to happen and then to support the motility. So we'll dive into that a little bit in a moment. But let's talk maybe a little bit about some myths and misconceptions. So we have 4 that we want to go over, and I can go over maybe the first one here. So a very common misconception is that more fiber helps with constipation and bloating, and this actually isn't true for some people. So we know that fiber increases stool bulk and can help in mild or occasional constipation, but in more severe or chronic constipation cases, sometimes fiber can backfire. And that has to do with the type of fiber. And I know we've gone over this a little bit in, I think, the FODMAP episode that we recently recorded, but it has to do with, like, for example, high brand cereal. Often patients will feel worse depending on their type of constipation, and that's because it's more of an insoluble fiber that they're reacting to, and that can lead to more gas and bloating. But interestingly, we also know that a low fiber diet should not automatically be assumed to be the cause of chronic constipation. So what the research shows is a lot of patients with chronic constipation will have normal or even high fiber intake. So they've already taken care of this. Like people want to solve their constipation. And one of the first things they're going to think about is like, do I have enough fiber or water in my diet? And often they'll take care of that before they come to see us. So constipation is really like multifactorial, and such as motility disorders, pelvic floor dysfunction, medications. There's a lot of other things beyond fiber and water that can be leading to issues in the bathroom. Some other misconceptions or myths that you guys have come across in conversations?
Yeah, I would add to the fiber one, just saying that lots of times people will be taking tons of fiber or those fiber gummies or fiber pills, but they're just not taking enough water with it. And so they definitely like make the constipation worse because all the hydration is kind of getting sucked into that area. So being mindful of that for sure.
That's a great point. And also knowing that there's different fibers too. And so it's not always like, so the Metamucil powder or the psyllium husk powder is not the same as like fiber gummies. That's often a different type of fiber. And some people may react to those more than such as like in the powder, which is a different type of fiber. So helpful information there. What are some other misconceptions?
What you talked about, Dom, with the Bristol Stool Chart is helpful to show people what a bowel movement should typically, what's normal versus more on the constipated side. Because sometimes they say, yeah, I'm having movement every day. But if we show them and they say, actually, it is a little bit firmer. And if we ask more questions to get this more detailed about it, as we do, then yeah, they start to notice, oh, maybe it is more incomplete, or I am straining more than I thought I was. So this misconception of having a bowel movement every day, that you can't be constipated, is a good myth to just highlight, because a lot of people notice that. So we can be having a bowel movement every day, but if it's not complete, it can give you that sense of like still bloating or sluggish, or like a sense of incomplete evacuation is what it talked about in the literature. But yeah, just that feeling of not feeling fully empty. So you can think about a water in a bathtub analogy. So if the water isn't flowing through the drain well, it will result in more and more backing up into the top of the bathtub. So we want that drain to be emptying fully every day. Otherwise, we are getting this backup of fluids and foods, and it will just lead to bloating. And then obviously distension, because it needs somewhere to go.
Yeah, I think of this also like when I describe it to patients about a tube, right? Or like we think about it as a pipe. And so the assumption is that there's nothing blocking the pipe. And so when it comes out hard, because the entire pipe is hard. And that's why sometimes we'll get diarrhea and then constipation is because it's not fully blocked, but something needs to kind of like slide by. It's like a sink that's a little bit stuck in the kitchen. Like some water still gets through, but maybe it trickles down the drain instead of it like whooshing out into the pipe. And so just thinking that like just because your stool sometimes is more loose does not mean you still couldn't have constipation, even with those boundaries.
We have a lot of good house infrastructure analogies today. The bathtub, the kitchen, the pipes. That's really helpful. I believe it's known as loose stool overflow. So we can get like this hard stool, but then we've got loose stool that slides around it. And still the approach is that we need to support the constipation. And ideally just make sure that stools are more like a type 4 on the Bristol Stool Chart more regularly. Yo, go ahead.
I was using misconception number 3 is like drinking more water relieves constipation. I actually have a great case about this. So we've got a woman who she was like, oh, I'm drinking lots of water. She's one of my regularly constipated patients. And I asked her to show me the water bottle and she brought it into the screen and it was crazy, like 2 liters. And she was drinking like 3 of those a day. And she was getting really like swollen and I was like, I think you're overhydrating. And she's like, yeah, but I'm still constipated. And so one of the strategies we worked on was like the water actually wasn't moving into her body. She still felt really thirsty, is like passing through because she had diluted so much of the minerals that her body needed. So drinking more isn't always better. There's like sort of a finite amount of how much do you need to drink based on, heating, air conditioning, sweating, what else are you consuming? How much caffeine are you having? So it's not that there's a universal amount for every person. I think that's sometimes one of the things where like, oh, well, I drink eight cups or I drink 8 glasses. A cup and glass is very different. And then there's also people that are just drinking those Stanley mugs like they're going to town. And so that's a lot of water. And so maybe part of what you need to consider is if you're having a lot of hydration and still having constipation, it's best to talk to someone about how much water should you be drinking. And, should some of that maybe be electrolytes or other types of fluids so that you're getting some of those minerals in. Even like herbal teas can sometimes really help. And so we can be dehydrated even if we've consumed a lot of water.
Yeah, certainly people don't put salt on their meals and also don't eat out. So it's all home cooked food, but they're not adding really any minerals into their food and they're drinking a lot of water. They may be more likely to be dehydrated. I do get a question often in clinic, which is, how much water should I be drinking? How much water means that, I could be dehydrated. So it seems that falling below about 4 glasses a day or under 1 fluid from drinks would make somebody mildly dehydrated, but we also have to keep in mind we get a lot of fluid from our foods like fruits and certain vegetables. So it needs to include that as well. Okay, and then I'll call this one a myth, but myth number 4 is that probiotics don't work for constipation. And so we wanted to chat about this a little bit because the evidence has evolved pretty considerably in this area. There was a 2022 meta-analysis that found probiotics and symbiotics significantly increased stool frequency and improved stool frequency in chronic constipation, outperforming placebo. But what's interesting too is that not all probiotics will work. If one probiotic doesn't help, it doesn't mean that the next one is not going to help. There's multiple strains, there's different doses. There's different forms. So probiotics is a little bit like of a dog's breakfast. And so working with a practitioner to really figure out if probiotics are helpful is a key part of this part here. Okay, so I have a question for both of you. What are some of the things we want to discuss or assess when someone comes to us needing support for constipation?
Well, we're diving into when this all started for them. For some people, they can say, oh, I've always been this way. So we're getting really clear about how long it's been going on, and then all about the bowel habits. So how frequently are you going throughout the day? I like to ask, how many days are you going without a bowel movement? So is it 1 day, 2 days? Because sometimes it can be more on the normal side versus we are actually calling this more constipation. So getting really clear about that. Bristol Stool Chart we talked about. So we'll show this in clinic. One day I will get it framed as a beautiful addition to my clinic walls. And then asking things like, are you straining? Do you see blood in your stool? Do you feel like it's incomplete? Is it hard stools? Are you using any laxatives? Are you needing to get this like through in other ways when this is like really uncomfortable? Because some people don't even notice that they are anymore. Oh yeah, I have smooth move tea every weekend, or I need this a lot more than I realized. So kind of getting clear about that. And then any triggers, sometimes after like a stomach bug, we talked about this before, but any alteration to the microbiome ecosystem. So after antibiotics, stomach flus, do you remember when this happened for you? What you've tried in the past. So have certain laxatives worked? Have certain probiotics worked? Has anything made it worse? So getting clear about, have you tried adding in more water? What types of fiber are you adding in? What's on that fiber nutrition label? What other types of fiber? Sometimes things like, and you might talk about this soon, but certain types of fiber like inulin can be really, really like flaring for a lot of people. It can just feed the microbiome and cause a lot of gas and discomfort. So we're trying to just look for any things that help speed things up or maybe contributing to the slowdown. And then, of course, we're always searching for red flags. So ruling out things like unintentional weight loss, any bleeding that you're noticing in the stool when you're wiping on the toilet paper, or if you've had any testing done. It's called a FIT test. So where you like collect your stool and you send it back to Life Labs. And then we're always looking at your blood work. Is there ever other evidence of blood loss, even if you're not seeing it? So iron deficiency or iron deficiency anemia, especially if you eat meat and your periods are not particularly heavy, we want to be more curious about where that iron is going. If you have fevers, so even if they're coming and going, that can be a pattern that we're thinking about. Any pain in your rectum or lower abdomen, any pain with that bloating, pain passing your stool. And then we're really getting more concerned if this is happening all of a sudden in older adults. So in our 50s, 60s, even 40s, we're starting to kind of screen more for colon cancers, really recommending those FIT tests or even referring for colonoscopy. So just really covering our bases. We do a really comprehensive overview of this full presentation for you.
I would add to that, is the constipation, when you do have a bowel movement, does the bloating go away? Because that can help us when we're thinking about this piece of bloating. Also, has the thyroid been checked, or is that issue? Because we see lots of people when their thyroid medications get changed. Sometimes the constipation is the result of that, and they don't even realize it, or they've forgotten to take it, or their dose changed. And also I have a lot of people that will come in as newly constipated after traveling or after hot weather. So there's a lot of like that dehydration. And so even though they've like come back to their regular habits, there's sort of this cemented stool stuck inside. And part of our job is to get the old stuff out so the new stuff can flow again. And so it might be even a temporary constipation situation where you're having it, but maybe it's only been a short period of time. And that may be as a result of something that happened. You got a flu or a cold. Yeah, you're in menopause and you're getting a ton of hot flashes and night sweats. So thinking about like, there's a lot of reasons why people might be getting more stuck stool. We talked a little bit about the fiber. And so maybe too much fiber or the wrong type of fiber or too little fiber. So people who are pursuing like low FODMAPs because they think that might be a relationship to their bloating, often have such a little amount of fiber that they're actually also not getting enough stool formation. And even things like gluten. So I always call gluten glue. So lots of people that have gluey stools will sometimes have a harder time getting them out, and they'll notice sort of those patterns if you can get them to recall, like, oh, what did you have before for food, things like that. Sometimes people with other food sensitivities like dairy or things that cause them more inflammation. And so it's not necessarily that you're sensitive to that food. You might be, but you may also be struggling with how to break it down in your body. And so it's creating more of like, yes.
Interesting point about the travel too, is if somebody comes back saying that their constipation improved when they are traveling, is we want to look at things like quality of food, but also if they were more relaxed, if they were moving more. So travel could be an interesting test for some people. And we've talked about, fluid and the amount of fluid. The goal that I will usually give to people that I discuss this with is about at minimum a 1.5 liters a day. But again, it depends on the person and adjusted for body weight, activity, climate, etc. And medication discussion is also important too. So this is often like a critical, possibly a missed step. There are many medications that we know can possibly cause constipation in some people. So those are the opioids, tricyclic antidepressants, your antipsychotics, anticholinergics, even iron supplements can do it. And that even can depend on a few other factors like the dose of iron. Often higher doses or the type of iron may be more constipating than lower doses. Things like antacids, diuretics. So there's a few medications. Not everybody who's on a particular medication may have a bowel response to it, but it's certainly something that you want to discuss with your practitioner. What else?
And a lot of the times, like, these medications can't be changed or adjusted. I used to work in cardiac rehab, and so it's like after a cardiac event and you're kind of put on this list of medications to stabilize them, and they need them, right? They're important medications to be on long term, but not a lot of people are asking about their bowel habits. These gastroenterologists are making sure they're stable, and then they're, admitting them to like an outpatient setting. So they have exercise therapists, dietitians, which is a great program, but this is an example of like, not everybody's following up on your digestion and your bowel habits, and you could be uncomfortable for years and no one said like, oh, this medication that you need actually has this unfortunate side effect. So I think it's always nice to have a second set of eyes and kind of reviewing your list of medications, and of course, if you're taking it properly, and then the side effects, that can be pretty straightforward, but we can really help with diet adjustments, exercise, movement. And then this too is bowel habits and toileting behavior. So we can help you kind of plan your day and your positions to have a more comfortable and complete bowel movement. So our bodies love a routine. I have 1-year-old, Dom has a baby too, so we can see how much they need these routines, but these timed bathroom breaks. So the mornings, attempts in the mornings after a meal, for example, to really leverage something called the gastrocolic reflex. So every time that food enters our system, our guts are going to feed back to the brain and the whole like mechanism of having a bowel movement to say, okay, it's time to go. So if you feel that urge, just really encouraging people to go, to not hold it, because that urge will go away. So just like, morning routine discussions is something we'll dive into. And then posture, the squatty potty or supported squat. So feet elevated on a stool. For a while there, it's really popular to get these high toilets, but actually we need to be a little bit lower with our legs up. So putting your feet up on a stool and then to really get into that posture, leaning forward, that really helps it straightens the inner rectal angle and reduces straining effort. So it's an anatomic position that can be really helpful.
I would say one thing that we didn't ask about in the history that might be really relevant is sometimes people are told if they have had a colonoscopy that they have a tortuous colon or like a longer colon. And so that generally means for people that they have more feet of colon. And so they have more dehydration because there's more water absorption. It's just in there for a longer period of time. I have a growing list. I think I'm almost at a dozen of these people now. And so some of their struggle is like that things are never normal for them because of that. The hemorrhoids would be also one. People have varicose veins, so we know there's like more pressure in the lower part of the body. And people without gallbladders. So we know that bile is a big part of the motility cascade. And so if you don't have a gallbladder, you're sometimes not getting reflux that Whitney related to in order to get the idea of like food in food or making space. We also see that sometimes people are using tools to be able to help them to get their stool out. And so we want to ask about, what are the tools that they're already using? And those might include medications. So sometimes people are prescribed medications from their primary care. Things could be like prucalopride or Constella. They work on different receptors in the small intestine to push stool forward. There's also lots of herbs that work in this area. So some people might say, oh, I use ginger tea, or I use other like herbal formulations, or I use things that support my gallbladder, and those seem to help or not help. And then that's sort of like upper GI. So that's below the stomach and before the large intestine. In the large intestine, a lot of the tools that we always think of classic constipation maneuvers are things that we want to learn about, the patient's using. So would that be something like PAG, which is called Restorelax, where we are, magnesium citrate or magnesium oxide, which work as these like, they pull more water into the colon to help basically loosen. I always say it's like a slip and slide. If there's no water on the slip and slide, you're not going anywhere. Bulk forming laxatives, so that's the things like this, mucil, psyllium fiber. We might have stimulant laxatives. So someone talked about smooth move tea already, or senna tea, or Wix-Lax, those types of like things that are kind of creating more urgency or more urge. There's stool softeners that people may be using, or also other types of medications that are more laxative inducing. And so sometimes people who struggle with constipation for a long time may have been given some of these. Maybe they didn't feel good. So they're like, oh, I went from constipated to having like really runny stool, and that didn't really help my bloating. Or maybe the runny stool did help my bloating, but then it aggravated my hemorrhoids, or it made it difficult for me to leave the house. So there's often like a longer story of, what are the things that people have tried? And so not just knowing what they tried, but did it help? Did it not help? Did they have to increase the dose? Did it help for a while and then it stopped helping? All of that can be helpful to understand more about what's going on, because as you started to realize, there are lots of reasons for constipation, similar to like there's lots of reasons for bloating. And if constipation is triggering the bloating, we want to make sure that we're dealing with the right reason why there's constipation, or else we won't actually know that that's part of the problem.
Yeah, that's really helpful. And yeah, we can maybe go into the causes right now, because as I think our listeners have determined, it's multifactorial. So when we talk about constipation, we want to think of it in really two more simplistic ways. So it's either one of the following. It's an obstruction of the luminal content movement, or it's poor colonic propulsive activity. And we can have primary functional constipation, or we can have more secondary, which means it's due to something else. So if it's primary, we're thinking of maybe normal transit constipation, which actually accounts for at least half of cases. We can have slow transit constipation. So that's more about 25% to 30% of chronic constipation cases. Or we'll have something called defecatory or pelvic floor disorders. And we didn't go into that too much, but that's more like a dysenergic defecation, where we seem to have like lost kind of that brain pelvic floor connection, causing issues with that rectocolic reflex. So when it comes to secondary constipation, we're not talking too much about that today, but that's more due to other conditions. So like things like uncontrolled diabetes, neurological issues like Parkinson's, etc. So maybe you guys can help me dive a little bit into more of the primary functional causes, and we'll start with IBS constipation. Maybe we can talk a little bit more about that.
So yeah, we'll dive into IBS constipation. And we've talked about this a lot in other episodes, but it's one of those disorders of gut-brain interaction. So there's a lot of causes to this, but essentially the definition is, and the key differentiator is that there's pain or discomfort that's associated with the constipation. And there's a lot of underlying factors. So we're screening for these things, but one of the main things is visceral hypersensitivity. So it's where the gut is oversensitive to normal levels of like food and gases and fluids moving through your digestive tract, any expansion or distension happening. So it's generating pain and urgency without anything wrong or anything abnormal. It's driven by gut-brain axis signaling, and they're just yelling at each other inappropriately. And there's a lot of like causative factors that go into this that we've talked about more in the Disorders of Gut-Brain Interaction podcast, so tune into that one. But other things that can be going on are mast cell activation, low-grade mucosal inflammation. So that's a whole other podcast that we have as well. There's a lot of histamine involved there and other chemical mediators in the immune system, so more immune-driven. Another thing is gut microbiome dysbiosis. So we need like a good ecosystem of a number of different species to help move the gut. And that can contribute to a slowed down gut, increased intestinal permeability, leaky gut. So things moving through what should be a tight gut lining, but instead they're leaking through into our bloodstream and showing the immune system that something is up. So again, it's like immune driven, like inflammation, low grade inflammation going on there. And then central nervous system processing. So for anxiety or catastrophizing, these things can really play into this irritable bowel syndrome picture.
And then there's the other side, functional constipation, which is more of a structural or mechanical potentially driven. So that's the pelvic floor. This is tight diaphragms. This is where we're not getting the gallbladder firing, motility, things along those ways. They generally have slower transit, but not always that pain or hypersensitivity, although you could still have pain because you're overfull, right? And so this might be someone who has X-ray that says that they're just like full of stool or backed up. And so remembering that even if you have one thing or one cause, it can trigger other causes. And so it's like a domino kind of falling over. It doesn't mean that every single one needs you to have a treatment for that reason. It just means that over time, these accumulate kind of snowball. And so we want to make sure that we're thinking about all of the reasons and not just the easy reason why somebody's experiencing this.
Yeah, that's really helpful. Okay, so to maybe start to conclude this podcast, let's maybe talk about some key practical takeaways, and I'll maybe just rapid fire through this. So things to think about: low fermentable fiber with enough water. And we talk about the fermentability of fiber. We've talked about that in a few other episodes, so we can link to those. Easy lifestyle tweaks, using a squatty potty or elevating feet, allocating enough time in the morning, trying not to be rushed. There is some really cool constipating supporting fruits, like kiwis have some interesting research behind them, but there's also dates, figs, prunes, papayas. We want to keep the bowels moving. Well, for most people, that is a goal. So discussing this with your practitioner on ways to help to do that. Talking about this with your doctor. If blood tests have not been done, then maybe that's a good idea to look in if there's more of a secondary cause of constipation here. There's a lot of really great gut-brain therapies like cognitive behavioral therapy, gut-directed hypnotherapy. I know we've talked about those in a few other episodes, but really focusing on the gut-brain connection, which can help with motility. And then there's always the refractory cases where sometimes people just don't respond to anything, and certainly working with family doctor, naturopathic doctor, GI specialist is really important here. And then considering maybe more imaging through their provider, like an ultrasound of the abdomen, possibly colonoscopy, fit test, or even motility testing, because sometimes it's truly an underlying motility issue. To take away here, if someone has constipation, how can they discuss this with their practitioner? And maybe you guys can help answer some of these questions.
So starting at the beginning of the podcast, like thinking about all those questions we want to ask our patients, bringing that information into your practitioner can be really helpful. So when did it start? What helps? What doesn't help? Is there pain? Is there discomfort? What have you figured out? What have you tried already that didn't help? Because anything that you can help to narrow down prevents you from drink more water, have more fiber, take a probiotic as a recommendation because you've already tried those things. So being upfront with that can be really helpful. And we have a long list of those in this podcast. So make sure that you go to the website because the transcripts can always go through and write them down very easily. Also things like a symptom diary or tracking chart. Whitney discussed the Bristol Stool Chart if you're feeling straining or bloating, which laxatives have helped in the past, and what are your actual goals? Like how often do you actually want to have a bowel movement, need to have a bowel movement? If a patient that only wants to have his bowel movement in the morning, that is his goal, not always the realistic goal. And then making sure that if you want to or need to have a referral to a gastroenterologist or a pelvic floor physiotherapist, depending on how your insurance or your province or state works, that you're asking about those other practitioners that can help you gather more information so that you're getting a bunch of different people in your situation.
I work with a pelvic floor physio for all of my constipation cases, and it's so helpful just to have them focus on their exercise patterns and that component, so we can really dive into all the other pieces and blood work and dietary approaches. But yeah, they can be really helpful. And then we talked about the transit time test. So tracking your transit time, there is a handout in the show notes for you called the Blue Muffin Challenge. How exciting. You get to eat a blue muffin and see what it comes out. And that's your transit time. So there is a normal range. So we're looking at that compared to when you see the blue and seeing how your stool is moving.
And if you see it more than once.
Yes.
And if you see it more than once.
Yeah. And what's cool about this is there's actually a few research papers to back up this method of the blue poop challenge. So it's a fun at home activity that we can do with the family if needed. So let's recap 3 main take-home points here. It's not always about having more fiber and water. There are multiple causes of constipation. So it's important to figure out if the constipation is primary or secondary. And as you can tell, based on this podcast, it is multifactorial. So working with a qualified practitioner is important. And lastly, it's usually not just one thing that will make a difference. It's often a combination of approaches and even a combination of practitioners. So thanks for joining us today to discuss constipation and bloating, because as you know, better gut health changes everything.
Thank you for joining Team Gut Girls. Like, follow, subscribe, and share our podcast with friends you think will want to know more about their gut. You can also visit us at teamgutgirls.com for show transcripts and more information, because better gut health changes everything. See you next time.